I think we're kind of coming to a new position. We're seeing a new horizon with understanding pain. It's interesting as we looked at pain as a quick snapshot over the last number of years. Originally, the suggestion pain was important as the fifth vital sign to be measured in the hospital. In addition to that, there was landmark case law suggesting the undertreatment of pain. Then there's this suggestion of the current prescription drug abuse crisis that we're in. And everything in between, the thought process with regard to how much do we know regarding responsible opioid prescribing, how to teach about pain. My impression, and many others the same, is that the reason why the go-to medication was opioids was because there wasn't a lot of knowledge regarding other treatments for pain. And so that suggestion in and of itself is what we try to do when we look at telementoring. And our solution to the issue with regard to pain medicine and looking at the snapshot is how do we instruct our current workforce to understand all the nuances about pain. The thought process was opioids were misconstrued as safe. No one told us, we didn't know that certainly long-term opioid use would have an influence on the immune system, would have an influence on the hypogonadal axis and testosterone. We had very little ideas in terms of how it can actually cause hyperalgesia, worsen pain. So the thought process was they were misconstrued as safe medications that unfortunately had these other nuances. It's not that there should be a moratorium or kind of opioid bashing, and that's just it. It's the suggestion that they're very potent and useful medications when done and used in the appropriate setting. It's just that they were used as a blanket kind of cover-up for pain where there wasn't really a diagnosis as to what was causing the pain. And that's kind of the difficulty that we find ourselves in now. What we know about opioids is that the difficulty is addiction in and of itself. If we're looking at that as one of the metrics or concerns with prescribing opioids, it's not there's no blood test for addiction, and it's a brain disease, it's a relapsing condition. And the difficulty is we can give opioids as a trial, and in that trial it was really the suggestion that it's a trial and then we have a surveillance period. And that surveillance period is very much key. The other issue is what risk factors do we know about patients that could tip us off, or at least as clinicians, that opioids may not necessarily be the best medication. If we look at this from the perspective of who are those patients that have had issues, the 2007 review by the CDC suggested that there were men 35, 55 in age, typically low back pain, history of substance abuse, and also a history of untreated psychiatric comorbid conditions, all wrapped up into one enchilada, a very powerful, spicy dish that could lead to potential addiction. If you take that bit of just observational data and then move a couple steps forward, in June of 2011, the Institute of Medicine put out a report called Relieving Pain in America, and it suggested that about 116 million Americans suffered from chronic pain, which was shocking to many. The suggestion, one, is how many people live in America and what a large percentage this was. But the second part was, if you then take the just general statistics that about 10% of the population has the particular proclivity or the genotype for addiction, that would suggest that there's a little over 10 million people that have chronic pain and addiction and may never have known that they have this proclivity to addiction. So at first glance, certainly surveillance is really important when starting an opioid.